So last time we have gone through the chapter 1, and chapter 1 was just, I will revise the basic idea. We have started with the history part was over, and after that we have approached to the part 2. ये तो हम लोगों का इधर किया हुआ था केसेस. So principle of interpretation जो discussion था कि what are the things we have to see when we are going. The first principle what GJ has also told. Rule number, always start reading from the surface ECG. Number 2, fix EGM color and order. Because if you are not fixing always, you will start struggling. When you are going the new labs, certainly you should first set what he has. Most of the labs what we see that the color and order is always fixed. Even for 10 years, they have not changed. So when they will be entering, and finally start making the sense of all the signals. Whatever in line with atrium, it will in line with P, it will be A, and what is in line with the QRS is V. And whatever the in between signals, we have to again have our own hypothesis. It can be like in his catheter will be, so anatomy as well as signal both has to be mixed. So sometime by seeing the catheter's position, catheter signal, we can say where the catheter is. Even when I am doing, he will say, sir, you are in the CS. How is knowing that I am in the CS? Because he has seen the signals. So likewise, it is possible to interpret where the catheters is by seeing the signals. This is what I already briefed, so I will not go in the detail. Always start with the study, and this is the thing what we are doing it. And second is the color. So color interpretation is important. Our color is, for his is, his, तुम लोग सबको बाहर कर रहे हैं. It is always yellow. ग्रीन किसका होता है? Yes. और व्हाइट किसका रहता है? Ablation and most of the RV catheters. Okay, so this color we should not forget. And third principle of interpretation. So we have to start making the sense. So you can see that here the V signal is coming. Here V, and there are a lot of signals, so we call it the late potentials. When we are keeping the same catheter in different locations, so the signals we should be knowing what signal can be present in that location. Then we have to pace and see the behavior of that extra signal, whatever is coming. So that part will be coming when we will be discussing regarding the signals. And this is a basic ECG. I will not go in detail because this all has been discussed. It is a normal sinus, tachy or sinus? Yes. Sinus, Ramda? Always start, where is the P wave here? Where the P wave is? See, the best part is whenever you are seeing, this is the HRA, high right atrium, and this is the A. You can see these are the A. There is no doubt in this one. And this is a V, or we can going the P. And here it is the his signals. Okay, so you can see this A is late and this A is early. What does it mean? Posterior part of the heart is being activated for, not the superior and superior part. So it means it always sinus means this should march first. After that, rest of the things. If any time you are getting this A signal first in the HRA, until proved otherwise, it is atrial tachycardia. Anything can be possible, but at least atrial tachycardia you should think about. This is a plain. I will not go in detail. Our today's thing is surface representation of ECG. So when we are reading the ECG, as an electrophysiologist, we never see the ECG as a what you call a depolarization, current of injury. There, our is total temporal association. How the P waves, how the QRS, what are the distance in between, how much time it is taking. Whether QRS is narrow means it is taking less time. If it is broader means it is taking more time. If it is taking more time, what can be the cause? and cause will be left bundle branch, right bundle branch, or interventral conduction disease. Whatever is there, depending upon that rules we have to follow. When it comes to the P, before P, what is coming? P is the activation of atrium. Before atrium, what get activated? Before atrium, what is activating atrium? SA node. So SA node, you can see the activation in the ECG. Can you see the what you call signals of sinus atrial node activity? It is indirect. Whenever you are getting a P wave, it is thought that probably sinus node is the first activated, and that's why the P wave is coming. Whether you are seeing the P wave of right atrium or left atrium. Both. Are you sure that it is both? When you are seeing the P waves, it is a right atrial activity or left atrial activity or both. QRS is right ventricle activity, left ventricle activity or both. Yes, you are correct. So when you are going to say that it is a left atrial activity is dominating or left atrial activity is left bundle branch block, right bundle branch, very easy to say. But on ECG, can you say that patient is having left to right activation delay? There is one name, Luna-D syndrome. Okay. By seeing the ECG, you can say the patient is having left bundle branch, right bundle branch. We are using the word for the ventricular activation. But when the atrial activation is also delayed, we can see by the ECG, the duration of the P wave will increase. And what is the duration? 140 milliseconds. P wave, anytime if it is going 140 millisecond more, we call as a Luna-D syndrome, or इसको Bayes syndrome भी कहा जाता है. So Bayes syndrome is indirectly means that the atrium is having intra-atrial conduction block. Intra-atrial conduction block. Ventricle की बात नहीं कर रहे. Both the atrium is activated through 3 channels. Number 1 is CS. Number 2 is foramen ovale. Number 3 is the most important, Beckman bundle. So Beckman bundle is the fastest conducting pathway between the right atrium and left atrium. When it is diseased or any dilatation of chamber happen, the current flow will be slow. Like LBB, RBB, intra-atrial activation pattern will take more time. So QRS will be wider. And that the same thing. These patients will develop atrial fibrillation. So by seeing the ECG, you can say the patient is having atrial fibrillation in the past. So that is the importance of seeing the ECG in the electrical axis. So what you are seeing here, P wave duration has increased, means there is a conduction time is taking more. Atrial is disease, so patient can be having atrial tachycardia, atrial fibrillation as one of them. Without seeing the ECG, you are anticipating. So take the patient in the cath lab, you will be getting the atrial fibrillation in that patient. Usually this has been described in the elderly patients. And 2012, this paper has come from there, all this. Now, coming to the ECG, basic ECG, 52-year-old male with hypertension with giddiness. What you are getting in this one? Sinus bradycardia, very good. Sure, it is sinus bradycardia? Rate is low, I agree with you, it is bradycardia. But it is sinus bradycardia or not? Always, whenever bradycardia happens, always try to see the T waves. Never ever comment sinus bradycardia without seeing the T wave and its morphology. See, you are seeing P wave is here, blocked. Whenever you are having doubt, you always bank on two, what GJ was saying, lead 2 and V1. Here you will get a proper P wave. So you can see the morphology of these and these are same almost. This is same. Now again you have to come here. This and some blip is coming here. So it is a blocked APC. Sorry. This guy. So when we are discussing the ECG in electrophysiology, we never go by the what I was saying, repolarization, depolarization. That is for the injury, for the intervention. Here we are seeing the electrical activity over the time. So we call as a ladder. Like a ladder, when the current is flowing the up to down, we have to see. So this ladder diagram will provide you whether you are dealing with SVT, VT, or junctional tachycardia or AVRT, even everything you can make by seeing. Means we have to train our brain by the approach through the ladder diagram. And this ladder diagram will give 90% of you know. If you are master this one, you can diagnose everything. So in the ladder diagram, what are the parts? So conduction through the heart, including the conduction system, is concealed from the surface ECG, which is our main part. Means we are not able to see the conduction, how it is happening. We have to give interpretation. And start your hypothesis first of the arrhythmia, and that hypothesis has to be confirmed in the ECG interpretation, finally reconfirmed in the cath lab, or you can say EP lab. So there are three टायर्स, फर्स्ट टायर, सेकंड टायर, थर्ड टायर. जैसे ट्रेन में होता है ना स्लीपर क्लास में, फर्स्ट टायर, सेकंड टायर, थर्ड टायर. अभी तो खत्म हो गया, 2 टायर्स ही होता है. So 3 टायर्स. So first tire will give the atrial activation, second tire will give the junctional activity, third tire will give the ventricle. And tire 1, you whenever we are taking the ECG, we have to pinpoint this is the activity which has started. Tire will find where the P wave is and begin with the place a dot in the top of the atrial tire. This represents the sinus nodal pacemaker. When the activity has started there. Tire 2, find where the AV conduction began and at the top of the P wave. Start of the P wave is the sinus nodal activity. Top of the P wave is the AV nodal activity, because it is not visual. You are just giving. Draw a line from that dot and beginning of the AV junction tire and point the beginning of the ventricular tire. And third tire is the beginning of the QRS to the end of it. So this is the thing what we normally, whenever ECG, you now onward, you should start seeing the ECG in the same manner. Never see that PQRS. PQRS ho gaya. This P you have just started. This is the atrial activity. Now you can see the peak of the P wave. Here the peak of the P wave is the start of the AV conduction. And QRS activity then start from here. So you just bring the line here. So QRS activity is coming here. So P, this is P, AV conduction, QRS. P conduct. Now, in this patient, our interpretation is it is a APC, VPC, junctional. What is that? I am saying first question is what is a means it is not to say APC, it is a broad or narrow. What is the hypothesis? First question is this is a narrow or broad? Broad. Why broad? ये दोनों एक जैसा लग रहा है ना? These both are of the same time. So it's narrow only ना? If it is narrow, from where it can start? Now your hypothesis starts from here. You are not able to see the P wave first of all. There is no P wave. The P wave can be inside the QRS or starting in the part of the or at the end. These are 3 locations. Now question arises. This is why it is not means it is. Whenever you are saying narrow, you have ruled out what? It is not coming from the ventricle. Ventricle will always and always, it will be broad. When broad is there, the narrow is not ruled out. Is it clear or not? This concept should be very clear. When you are dealing with the narrow QRS, it means that it is starting above the AV node. Then only it will be narrow. But if a QRS is wide, it can be above or below. Both the possibilities there. Above also, because there is a bundle branch block has happened, it will become broad. But broadening will never happen in the above the AV node most of the time. Sorry, narrow will never present above the AV nodal. So this is atrial, it will be junction. These are the 2 possibilities. Now we have to give an interpretation from where it is coming. So first you should connect there. Okay. So ventricle part, you are the QRS is started, you have it blocked here, and you have to try to search. If you are getting a clear-cut P wave starting onset, you can say it is a sinus or APC, which is not been which is conducted. There is one possibility. Second possibility is that there is no P wave or P wave inside the QRS, which is most likely in this patient. So you can think about there is a junctional which has been conducting down. So this is the part one. After that, you have to again get into, I mean, the EP part two will start why the patient is behaving like this one. One beat is coming in junction, which is not a behavior. Junction APC's junction beat should not come. Okay, what you are getting here? Lead to 1, 2, 3, 4. So these are the P waves. P is more than QRS means when the waves, P complexes are more than QRS, what does it mean? Some block is going on. Is it clear or not? When we use a complete HUD block, it means P activity is more than QRS and it has not been conducted. Bradycardia can be due to a lot of reason, but complete heart block, AV dissociation जब रहेगा, then we call it a P wave more than QRS, and the AV dissociation, then we call it a third degree wave. If there is any association, it can be type 2, and if all the conduction is going on, that is a type 1. Type 1 means a first degree AV block. So it is what exactly it is. Any interpretation? Third degree AV block. Tell me one thing about third degree AV block in this one. Who has told? Come forward. तुम बोले थर्ड बता how it is third degree AV block. Regular QRS, are you sure?
No, sir, it's irregular QRS.
Irregular QRS, चलो मान ले, yes. That can happen. If you can show one complex in which P and QRS is falling on each other, then it is third degree. I will not ask any question because until proved other, if this P wave is falling in the QRS, means AV dissociation is happening. Here the P wave is happening, and there is first of all you can see there is a regularly irregular. It is not a totally irregular tachycardia. So P wave is coming, P wave is not conducted, P wave is conducted, P wave is conducted, P wave is not conducted, P wave conducted, P wave conducted, and some P wave is here which may not be conducting. That's why there is a gap. So always whenever you are seeing the ECG, you have to start making the same ladder diagram. Ladder diagram point of view, you can see here we are not getting the initial part. Now started. This P wave started from here. It is okay. P gone. It is blocked here. And this is the what you call QRS, which is being conducted down. Here it is what you call it is normal conduction. Again, this is a junction which is going down, and from up the P wave which is coming, it is getting blocked. Conducted, junction. So junctional escape is coming, and a slow and fast pathway both are coming. One is getting blocked, and the tachycardia is not happening. Okay. This is second ECG. So whenever you are getting, you see, this is whenever we are getting a narrow QRS, always think from where it can come. It is only one place, that is node. Okay. If it is broad, then it can be from node or below also. Both the things is there. But when it is coming in a narrow, it is there. Now in this, you are able to see what is happening here. It is narrow. We are not discussing about this. A P wave is coming. P wave is inverted here. QRS. Here you are getting P wave. P wave. So what is this P waves? The retrograde P waves. So here it is a VPC. VPC has gone up, and after that it is being conducted above and it is coming up. So हम लोग slow and fast path दोनों के बारे में सोच रहे हैं इसमें. ऐसा नहीं कि it is one. It can go directly fast. It can go slow, and like that it is going on. So showing this ECG is only to make that whenever you are making any interpretation, try to make a ladder diagram in your mind and try to give some interpretation. What are the hypotheses in that? I think this has been already been discussed, EGM versus ECG. So ladder diagram is an important part of this one, which whenever you are taking a ECG, narrow QRS, always think that either it is junction or APC getting conducted through the AV node. There's no other way. And then we have to start the hypothesis P wave is positive versus negative. So if you are able to see the P wave, you can think about it. Okay, P wave is coming and is negative, means it is coming from down to up activation or up to down activation. So today we will pause at this one. Next class again we will go further. Okay. Thank you everybody. Yeah.